Welcome everyone to our second webinar on TriClip therapy. My name is Sarah Johnson and I'm a Senior Product Manager at Abbott Structural Heart. Tricuspid transcatheter-Edge-to-Edge repair is so critically dependent on imaging and the imager. So we've brought together experts from two highly experienced centers to discuss a very important topic, TEE screening for TriClip therapy. I'm pleased to introduce our expert panel of presenters. Dr. Stephen Little is the John S. Dunn Chair in Clinical Cardiovascular Research and Education and is the Houston Methodist System Director for Structural Heart and the Program Director for the Cardiovascular Disease Fellowship Program at Houston Methodist Hospital. A longtime member of the American Society of Echocardiography, Dr. Little previously chaired the ASC Guidelines and Standards Committee, as well as the Structural Heart Disease Task Force. He is the past president of the ASC. Dr. Lucy Safi is an associate professor of medicine at Icahn School of Medicine and currently works as a structural heart imager and interventional echocardiographer at the Mount Sinai Hospital in New York City, one of the highest volume sites for TriClip interventions in the US. She completed her cardiology fellowship at Cooper University Hospital and advanced echocardiography fellowship at Massachusetts General Hospital. Dr. Safi has been an active member in the American Society of Echocardiography and currently serves on the ASC Board of Directors. Both Houston Methodist and Mount Sinai participated in the TriLuminate pivotal trial, and they were among the first centers in the country to treat patients with TriClip soon after we received FDA approval. We are so pleased to have their wealth of knowledge and experience with us today. Here's our agenda for today's program. First, Dr. Little will provide a refresher on TriClip therapy, including the indication and which patients are best for a tricuspid edge-to-edge repair procedure. We'll also review the anatomy of the tricuspid valve and how this requires a strong proficiency in imaging, given the unique challenges of this valve. Dr. Safi will then take us through the basics of the TEE screening for TriClip, including the required views, leaflet identification, and measuring gaps. Before we get started, just some quick housekeeping reminders. This webinar is being recorded and will be available for on-demand viewing. Questions can be submitted at any time through the Q&A feature on your screen, and you will be receiving a survey afterwards. And we really appreciate your feedback on the program. And I'll now go ahead and hand this over to our first presenter, Dr. Stephen Little.
Thank you, Sarah. I appreciate the introduction, and it's a pleasure to be joined by my good friend, Lucy Safi, for this presentation. We'll start with some basic review of the device, the platform, and patient indications. So this should look familiar to you. This is a graphic of the setup. The business end at the bottom right is the TriClip, which is technically very similar to the MitraClip, if you're familiar with that. There's a similar setup, the catheters, there's an SL knob and an FE knob and a big sled that we're all familiar with. So this is really the details that the interventional cardiologist or surgeon potentially would be working with. But just so you understand, it's very similar to the MitraClip setup, but is specific for the TriClip therapies. The indications for use are important to quickly review. The TriClip G4 system is indicated for improving quality of life and functional status in patients with symptomatic severe tricuspid regurgitation despite optimal medical therapy and who are at intermediate or greater risk for surgery, in whom transcatheter edge-to-edge repair is clinically appropriate and expected to reduce TR severity to moderate or less, as determined by the multidisciplinary heart team. There are some contraindications, basically those if intolerance or an allergy or an hypersensitivity to the procedural anticoagulation, treatment hypersensitivity to implant components, particularly nickel, titanium alloy, or cobalt chromium alloy. Active endocarditis or other infection of the tricuspid valve would also be considered a contraindication. So one of the common questions is, which patient are we really screening for in these procedures? On the left are the ideal patient parameters, so severe tricuspid regurgitation, typically 3+ or greater. Anatomy that's suitable, so typically functional or primary, and we can talk about both. Normal or mild RV systolic dysfunction, so not the severe RV systolic dysfunction ideally. Mild to moderate pulmonary hypertension is acceptable. Treated left-sided disease, not untreated. So for example, severe active mitral regurgitation would not be ideal for a tricuspid intervention, and on appropriate guideline-directed medical therapy, which is typically sodium restriction, water restriction, and diuretics as appropriate. The contraindications are effectively asymptomatic or mild or moderate TR, so not enough TR or the absence of symptoms, anatomically not suitable, or rheumatic or very complicated anatomy. We'll talk a little bit about that in this webinar. Severe RV dysfunction is definitely a concern. Severe untreated pulmonary hypertension is a concern. Really untreated severe left-sided heart disease, and then not on guideline-directed therapy. So some aspects of the T that we really want to sort of emphasize in this webinar, you really have several roles as you perform screening TE. So you have to identify the pathology and the mechanism of TR. So roughly 90% is functional, but not all. And it's important to identify those patients with primary tricuspid valve dysfunction. You have to look at the imaging quality. So in the baseline screening TE, hopefully the image quality is sufficient to answer several key questions around mechanism, gap, really trying to understand, is the imaging quality sufficient to perform an image-guided transcatheter therapy? That's to be evaluated during the screening. The suitability for TEER as a treatment, so typically that gets down to leaflet length and the gap width. Where would you put the clip, and is it expected that the device would actually traverse the gap? And the screening ideally should be performed by somebody who's very familiar with the requirements of the actual of the procedure. It doesn't necessarily have to be a procedural imager who does the screening, but certainly have to be very familiar with the unique views that are required of the screening to make the assessment of patient selection. And we'll talk about the transgastric short axis, the RV inflow view, and the mid-esophageal view, particularly with multiplanar reconstruction. So those are some of the highlights of what we need to review. To pause for a minute on the anatomy, and many think they understand the tricuspid anatomy, but as the imager, it's important to sort of pause here and look in a little more detail. The graphic on the left is particularly useful. We're all familiar with the mitral, and many of us performing these procedures or screening in the tricuspid space have some experience in mitral interventions, and we understand the coaptation line and the commissures evident on the mitral valve. But this graphic really does nicely show a reality of the tricuspid valve, is that it's almost like you took a mitral valve and you rotated it counterclockwise. There's a long commissural coaptation region between the posterior and the anterior, and that is often the target for therapy. So the septal anterior gap is often the main target. A secondary target potentially is the septal to posterior. Very rarely will be an anterior to posterior target. But recognizing that there's almost a major and minor line of coaptation is important as you strategize around where to put the TriClip device. The red line does indicate typically where the pathology happens. It's annular dilation, typically in the posterolateral plane, as shown there. And if you look over on the graphic on the right, it again shows sort of how the RV tends to dilate. And in considering the mechanism of functional TR, it's often two things. It's the component of annular dilation or ventricular dilation with significant leaflet tethering, and often both of those things. So sometimes you're battling a leaflet tethering and annular dilation. In some patients, it's mostly leaflet tethering. In other patients, it's mostly annular dilation, but it's usually some combination of those two features that we have to be reviewing. So this was an important paper just a few years ago, really highlighting that if you do a very detailed sort of scallop analysis, that not everybody has three identifiable leaflets of what's called the tricuspid valve. And this is a nice depiction of how that can be broken down. Type 1A is how we like to think of it, with three distinct scallops. But you can have, for example, type C3A, where the anterior is sort of broken into minor pieces. But one of the more important elements of this graphic is the little blue dot. The little blue dot actually represents the anterior papillary muscle. And that's an important landmark because that actually defines the difference between the anterior and the posterior leaflet. So how do we know sometimes what's anterior? How do we know what's posterior, particularly if it's multi-scalloped? Well, when you identify the anterior papillary muscle, that really defines what we sometimes refer to as the AP canyon, or the difference between the anterior and the posterior leaflet. So that's an important landmark. So as a An imager, these sort of basic anatomic considerations are quite important. So this is another display of how we tend to put tricuspid valve dysfunction into various bins. There's atrial FMR, so obviously the vast majority have longstanding atrial fibrillation typically, and it's predominantly annular dilation, sometimes with no evident leaflet tethering. So the RV size and function is often normal. There's very little tethering of the leaflets, but the annulus is very dilated. That actually can make it somewhat challenging because you don't have a huge coaptation reserve. The more common one is ventricular functional TR, where you have some combination of annular dilation with tethering, and by definition, truly, RV dilation and RV systolic dysfunction to some degree, hopefully not more than mild for these patients' consideration. Cardiac implantable electrical device, so pacemakers and AICD leads. That's tricky, and sometimes they're just adjacent to an area of TR. It can often take a fair bit of investigative work and sometimes some historical work to determine if it's actually causative of the TR or just associated with the TR. And then you have organic or primary. A typical scenario there might be somebody who's had a heart transplant, who's had a biopsy misadventure, and now they have a flail tricuspid leaflet because of a ruptured cord. Or sometimes it's just primary TR with myxomatous disease with or without flail. So, but they are not common, but they're still 10% or sometimes 20% of a large patient cohort. So looking back at that anatomy, it's important to recognize where our basic working views come from. So the top right, the red line is 0 degrees on a TE mid-esophageal. And you can see that if you superimpose that, you would get a 4-chamber view. You would cut across both atria, you would cut across both ventricles, and you would be imaging from the septal to something. And we sometimes refer septal to lateral, and we often use the word lateral when we're not sure if it's actually the anterior or the posterior. So that would be a septal lateral plane at 0 degrees. The other main working view we'll often use is what we refer to as the inflow-outflow view. That's the red line at the bottom. If you sort of pulled that across the tricuspid valve, you would get the inflow of the RV and the outflow of the RV. That will generally give you the septal leaflet, but now it's the septal in the anterior or the septal in the posterior from a different view. So those are the two main working views. And as a screener in these patients and doing the TE for identification of treatable TR, these are the two views you get most comfortable with: 0 degree, 4-chamber, and the inflow, outflow, somewhere around the 60 to 90 degree range, depending on the patient. This is from the ASC screening for structural heart disease and intervention guideline. Really just to emphasize that we're used to an upper esophageal view, we're used to a mid-esophageal view. There is a fairly novel concept, and that's the deep esophageal view, and that's shown as sort of the third one down with the red line. And then transgastric and deep transgastric. The deep esophageal is important to sort of pull into your classic or your sort of checklist for these cases. Not only is it on the way to transgastric anyway, but it gives you a view of the tricuspid valve and the RV that generally gets rid of the left-sided structures. So when you have mitral prosthesis, sometimes if you have an aortic prosthesis, if you want to sort of image less of the left heart and just focus on the right heart, the deep esophageal view is typically the one that allows you to do that. An example, again, of the importance of patient variability. We don't routinely do CT scans for this particular intervention for TriClip. However, often patients will have had it for another reason. But this is just to show you an example of the orientation on the patient on the left of where the esophagus is with the star versus where the tricuspid valve is. And it's not straight ahead, it's far off to the right. So in this scenario, you might have to use a small wheel, you might have to get comfortable doing some small manipulations within the esophagus. On the other hand, on the right, you've got an esophagus that's almost directly posterior to the tricuspid valve, and you generally can expect to have good imaging. So sometimes it truly is the patient, and some patients require a little more finesse and a little more wheel play to get images that are satisfying. And then the other main area of expectation when you're doing these cases, again, looking at the 4-chamber view as shown here, recognizing that simply scanning anterior within the 4-chamber view or posterior in the 4-chamber view will give you different cut planes. and those are nicely labeled. And how do you move anterior and posterior? It's basically just antiflex and retroflex. So very small motions on the big wheel, a little bit of antiflex will take you across the septal and anterior plane. Just a little bit of retroflex will generally move you across the septal and posterior plane. And that's shown in the two images at the bottom. So just getting sort of comfortable of what's anterior, what's posterior. A useful marker when you do scan posterior is you often begin to see the coronary sinus come into view. So just getting comfortable with a little bit of mid-esophageal antiflexion and retroflexion is also very helpful in these cases. So without further ado, I would like to introduce Dr. Lucy Safi, who's going to take us through a little more detail in these concepts and really show you what I think are some beautiful images. Over to you, Lucy.
Thank you, Dr. Little, for that kind introduction, and also thank you to Abbott for having me here today. So I'm going to jump into the basics of TE screening for the TriClip procedure. And as already discussed in detail, the importance of the 0-degree view. Here you can really take a look at the RV function, you can take a look at the right atrial size, and then also your goal for these pre-procedural TEs is really to determine the anatomy of the tricuspid valve, confirm the diagnosis of severe TR, and also plan for intervention. So we really want to take a close-up look at the tricuspid valve leaflets. So here at the 0-degree view, you can see nicely the septal leaflet in the center there adjacent to the ventricular septum, and then the lateral leaflet, which may or may not be the anterior or posterior leaflet, depending on how much flexion or antiflexion is on your probe. And as Dr. Little already mentioned, you're slicing through the tricuspid valve here in this horizontal plane. And in this horizontal plane, you're cutting right through the anterior and the septal leaflet. When you advance your probe into your deep esophageal view, you'll start to see the coronary sinus entering in. So in that right image there, that is a picture of the distal esophageal view. And in that view, you can see the septal leaflet adjacent to the coronary sinus, and then the posterior leaflet just adjacent to it. At 0-degree, you can evaluate the degree of tricuspid regurgitation. Again, you can see the entire jet, both on the left there in the mid-esophageal view, and also in the deep esophageal view there on the right. In order to get better aligned, especially in patients with a horizontal heart, don't forget to use your small wheel, and right flexion is helpful in these patients to really try to align your annulus more horizontal in the center of your screen. The RV inflow view is usually our next view, and this is obtained, as Dr. Little said, usually between 60 and 90 degrees. Your goal should have an image that looks like the one there on the left, a nice horizontal tricuspid annular plane. You should be able to see the aortic valve in this view, and you're cutting the tricuspid valve, as you can see here, with this horizontal line right through the anterior septal and posterior leaflets. And so when you're cutting through in this plane, biplane is incredibly helpful. And when you use biplane in these images, your biplane cursor, when it's closer to the anterior portion of the tricuspid annulus, as you can see in the top right part of your screen, when you cut through the anterior part of your annulus, you will see the anterior leaflet and the septal leaflet in your orthogonal plane. As you start to move your biplane cursor more towards the posterior annulus here, you'll start to see the septal leaflet on the left and the posterior leaflet on the right in your orthogonal plane. This RV inflow view is your working view. It's a very important view when you're doing a TriClip procedure, and being able to map the tricuspid valve in this view is extremely important. So we take our time and we sweep through at this view and we obtain multiple images. And what I do is I take my biplane cursor, I start as close as I can to that anterior valve and that anterior part of the annulus, and I acquire that image. And then I turn on color and I acquire the image in the exact same location. And what I'm doing is I'm slowly sweeping across the tricuspid annulus from the anterior to the posterior. So I start here, and then I slowly move my biplane cursor more centrally, and I acquire that image with and without color. And then I move it more posteriorly, and I acquire it with and without color. really nice way to sweep through. And when you're sweeping through in the orthogonal image, what are you seeing? Well, you're seeing the leaflets at that exact point in the annulus. So you get to assess leaflet motion at that point. You get to assess where the chordae are inserting, how restricted are the leaflets tethered. You can actually freeze frame and measure the leaflet lengths. And you understand the anatomy of the tricuspid valve very well when you're sweeping through. So there's never too many pictures to obtain. Go ahead and sweep through the tricuspid valve and the RV inflow view. And then you can advance your probe into the deep esophageal view. And as Dr. Little mentioned, you're eliminating a lot of the shadowing from the left side of the heart, any kind of acoustic shadowing from prosthetic material or even septal hypertrophy when you advance into your distal esophageal view. And then you can go ahead and sweep through with and without color, as I mentioned previously. The 140 to 180 degree view is essentially an inverted 4-chamber view. And this view is helpful in order to assess tricuspid regurgitation as well. Now, when you're reviewing these images, you're not sure exactly the level in the throat. So if you're a little higher, you can be imaging your anterior and your septal leaflet. Or if you have a little bit of anteflexion on, again, you'll be seeing your A and your S leaflets. Whereas if you're more of the mid-esophageal with slight retroflexion, you're imaging your posterior and your septal leaflets. So when you're evaluating these patients, you want to assess for leaflet motion, any chordae insertion. And actually, this is one of my favorite views for aligning the CW cursor and assessing pulmonary pressures. The last view I'll discuss is in 2D is the transgastric view. And this is the only 2D view in which you're able to see all 3 leaflets at the same time, and you see them in short axis. So when you're trying to determine the morphology of the valve, whether it's a bi, tri, or quadricuspid leaflet valve, this is really your main view to do so. So in the short axis view, you can see your septal leaflet, anterior leaflet, and posterior leaflet en face. And then you're also able to turn on color. And when you turn on color, you're able to see exactly where the regurgitant jet is leaking from and the coaptation plane. So this will give you thoughts on your technique and strategy intraprocedurally. You do have to make sure that you're at the leaflet tips because you could really overestimate the amount of TR if you're not quite at the leaflet tips. So using biplane to confirm that you're at the leaflet tips is helpful in this view. And you're also able to obtain 3D, and that will help you determine whether or not you're at the leaflet tips. So who's a suitable candidate? Well, there was a study that evaluated coaptation gaps, and they used a cutoff of about 7 millimeters in terms of a malcoaptation gap. And in patients with smaller gaps, defined in this study as less than 7, with a leak that originates from the anterior and septal commissural plane or coaptation plane, they had a very favorable success rate in terms of TriClip procedure. Conversely, those that had larger gaps in this study defined as more than 7, with their regurgitant jet not originating from the anterior and septal plane, those patients were much more challenging in order to do the clip procedure. And so, as I mentioned previously, measuring the gap is helpful. You can do it from your transgastric view as long as you confirm that you're at the leaflet tips. You can also build your 3D MPR of that volume set and measure it using MPR. There is a 5-grade grading system for tricuspid regurgitation that we now commonly use: mild, moderate, severe, massive, and torrential. And these are your points for reference if you want to refer to it when you're grading your pre-procedural tricuspid regurgitation. NPR I did mention, and it's an extremely important technique to be able to use during these procedures. We will have a dedicated webinar on just multiplanar reconstruction because it is so important. But just briefly here, multiplanar reconstruction is a technique that is used to align your planes on the 3D volume set in order to get the best view to determine grasping for that particular patient. So TE imaging toolbox, what do you need to know? You need to know your 0-degree view, you need to know your RV inflow view, your transgastric view, and if you are able to get volume sets in order to build your NPRs, and this could be done offline, you want to go ahead and obtain that. The goal of this, again, is to confirm the degree of stenosis, to to identify the mechanism of TR and to evaluate the anatomy for pre-procedural planning. So in order to obtain these views, it will make it much easier for the heart team in order to decide how best to treat these patients. So when you're obtaining all these images, you want to improve your image quality in order to really give the patient the best TE possible. So don't forget to optimize your gain setting and not just use your total gain up and down, but really use your TGCs on the left there, usually on your machine, in order to get the best gain that you can for image quality. You want to use small sector widths and zoom in on the things that you're imaging at the time of the procedure. If the patient is intubated, you could take advantage of that and use low tidal volumes and increase your PEEP in order to optimize your image quality. And always make sure that when you're imaging a patient, that they're diuresed and optimally medically treated prior to your procedure. So just in summary, your inflow view is a very important view. It's your workhorse view. Make sure you use your biplane and sweep through the valve in order to determine the mechanism of tricuspid regurgitation and to assess the leaflets in detail. You want to avoid views with acoustic shadowing, and this is done very well in the deep esophageal view, but you can do it in all views if you use your other gain settings and optimize the image as best as you can. You can use the small wheel to better align with the tricuspid valve and avoid acquisition errors when you are imaging with just simple things like if the patient is in AFib, you want to acquire in seconds and beats if they're in sinus. So putting it all together, what does the procedural TE tell you? Well, it will confirm the diagnosis of TR. It will identify the etiology of the disease state. It will give us a good look at the tricuspid valve anatomy and the origin of tricuspid regurgitation, which will help us plan for intervention. And these images, we do take a look at them pre-procedurally to plan. We identify the best angles, the best views for the patient to really reduce the interprocedural time and hopefully minimize complications.
Thank you, Dr. Safi. And thank you, Dr. Little, for taking us through the TEE screening. We'd like to open it up now for a few questions, and I do have a few questions for you here. So the first one is, when you're thinking about the TEE screening and who to send for a TEE screening, so what should a reading physicians that are reading transthoracics, what should they be looking for to determine, should I actually move this patient forward to get this full transesophageal assessment to see if they're a good candidate for TriClip procedure?
You want to take that one, Lucy, or I can? Go ahead.
Sure. I think, when you're a physician taking care of a patient who has severe symptomatic tricuspid regurgitation, if they are optimal medical therapy and you're reading their echo and they still have severe or more tricuspid regurgitation, I think that should automatically be a trigger, especially if they're symptomatic, to maybe investigate this further and have that conversation with them about the TriClip procedure.
Great, thank you. Specifically for the TEE, you had mentioned deep esophageal earlier on as an option. I'm curious from each of you, how often do you use a deep esophageal in the TEE screening?
I'll jump on that. I mean, I would say if the specific question is TR severity and suitability for this therapy, it would be 100%. So you always want to do a 4-chamber view. You need that to identify leaflet pathology and RV size and function. But as you go into the transgastric, which is a required view to get a short axis of the tricuspid valve, you necessarily have to do a deep esophageal anyway. So just sort of recognizing to pause there, to reestablish good contact, to recognize that you want to eliminate most of the left-sided structures from that view. And you get different views of the tricuspid valve. Sometimes you use the color to guide you to the big jet, but sometimes it doesn't add new information, and sometimes it does. But it takes just a couple of seconds. It's important to work that into the workflow. And I would say when the indication for the study is tricuspid valve evaluation for TriClip therapy potentially, it's an important view to do in everybody.
Yeah, and I echo that. I do it on everyone, or at least I attempt. And so I do all my mid-esophageal images first, and then I advance the probe into the distal. And if the image quality is great, then I do acquire at least the RV, the inflow view in that deep esophageal as well. And I build some NPR in that view. But if the image quality is not good, then I actually do annotate on the screen, deep distal esophageal, and I acquire, whatever image I have. If it's poor, at least to know people if they're auditing the TE image that I tried. And then I just move forward and I go to my transgastrics and I obtain them. So I do attempt on everyone, and if it's not good, I document that it was not good.
Okay, perfect. Another question we have, if you see that a patient has a CIED lead during the TEE evaluation, what are things specific to leads that you're assessing in terms of suitability for TriClip?
And I'll jump on that. The question you're trying to really answer is the lead causing the problem? That's usually the first question. Is it somehow pinning a leaflet, which is more often than not the septal leaflet? That's often a question. The next question is, if it's not pinning the leaflet or responsible for the TR, is it in the way? Is it something you would have to just deal with or work around in the efforts to deploy a TriClip? Very helpful for that is the short axis transgastric view to see, if the lead is buried in that septal posterior commissure. That's usually ideal. That's where you like it. It's sort of least problematic. If it is buried in the anteroseptal commissure, that's usually okay, but more often than not, you'll be putting a clip in that area, but you have to be a little more cautious. But if the lead is sort of in the area of the peak, if you will, of the septal leaflet, and there's a lot of color there, then you have to do a little work, use your NPR, use your X-plane, trying to use your grasping view at the mid-esophageal 140, try to determine, is that septal leaflet being affected in its motion by that. So and unfortunately, we're seeing more and more of these cases with implanted cardiac devices and leads. But I also think that we're probably recognizing as a group they're less causative than we initially thought, and mostly it's just something we have to work around.
Mm-hmm. Right. I mean, the leads could be just an innocent bystander. It could be there and not really interfering with the TR jet at all. Or it could be, as Dr. Little mentioned, really causing a malcoaptation gap and significant TR. So identifying the difference. And also, some of these CIED leads can cause acoustic shadowing themselves, depending on how they're traversing through the tricuspid valve. So when you're doing pre-procedural imaging, it's nice to see, not only is it in the way, but is it shadowing on where you would want to clip? And so all of those could be identified. And usually the best view, as Dr. Little mentioned, is the transgastric view.
Okay, that is very helpful. You also mentioned earlier on in the discussion here about having a procedural imager involved in the TEE screenings. Can you comment a bit on why it's important to have that same physician that will probably do the procedural TEE involved in doing the TEE screenings?
I would say it's not a mandate. It doesn't necessarily have to be, but it is certainly convenient. And the reason being, there are some of these views that we've talked about that may not be standard practice for somebody who's not involved in the specific screening for these cases or the implant. For example, it does take a bit of practice to routinely get a short axis view of the tricuspid valve. If you just said to somebody who's familiar with TE but doesn't specifically do that on a routine basis, it's not obvious how to quickly get that. There's sort of between 0 and 50-degree angulation and just the right amount of flex on the probe and a little bit of right wheel, and those little movements take a little time to practice. So that's an important one. The importance of the deep esophageal, as we've discussed, is not necessarily known to folks. And even just how to use the X-plane to reveal septal and anterior, or septal and posterior, those become fairly second nature to implanters and imagers involved in the implantation procedure, but they're not always known. So somebody who dedicates themselves to the screening requirements can certainly do it without being an operator, but it's convenient if it's the same person.
Mm-hmm. Right, and the pre-procedural imaging can also help you identify, if the image quality is poor, can help you identify those patients that you may need additional support intraprocedurally, like with ICE, for example. So if you have a very good physician that knows the views and did the best they can, and the image quality is still suboptimal, then those patients can get flagged that they may or may not need ICE intraprocedurally. Whereas, if you're not familiar with the technique and you struggle during the pre-procedural TE, then you don't know if it's technique and that's why the images are poor, or if it's because the patient has challenging images.
Okay, very helpful. Well, thank you. That's all the questions we have for today. I want to thank you again, Dr. Little and Dr. Safi. I think we learned a ton here today on TE imaging for TriClip therapy. This will conclude our discussion. Thank you to everybody who joined, and we hope that you please stay tuned for our next webinar, in which we'll be discussing NPR in much more depth. And we'll hope that you join us for that one. All right, thank you and take care.
Bye-bye.